to PGOG, Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is aspirin and heparin in pregnancy. Aspirin is acetyl salicylic acid. It is a cyclooxygenase inhibitor. It has anti-inflammatory action and antiplatelet action. Now, its antiplatelet action is whenever it is being used with a low dose, whereas whenever an adult dose is being used, it has anti-inflammatory action. Let us see how the action differs with the dose which is being used and why we use mainly, especially during pregnancy, why we are using this low dose aspirin and not the adult dose. So what is happening here is, just a minute. Arachidonic acid, it is getting converted, arachidonic acid, it is getting converted to thromboxane A2, for which it requires an enzyme which is COX-1. COX-1 is cyclooxygenase 1 enzyme. This we should remember that what it requires is the cyclooxygenase 1 enzyme. So this arachidonic acid is getting converted into thromboxane A2 because of the action of this, because it has with the enzymatic action of this cyclooxygenase 1 enzyme. Now aspirin, when we are giving in the low dose, this is important. Whenever we are using the low dose, then it mainly prevents action of this COX-1. COX is for cyclooxygenase. COX-1 enzyme action is prevented whenever we are using aspirin with a low dose. So what happens is thromboxane A2 level falls. This thromboxane A2 level, it is reduced whenever we are giving low dose aspirin. But whenever it is being used in a low dose, it has no action on prostacyclin. This is important, that it is not affecting the level of prostacyclin. What it is mainly affecting is only the thromboxane A2 level, which is getting reduced. That leads to the imbalance of the between this thromboxane A2 and prostacyclin, so that the prostacyclin action is becoming more pronounced and thromboxane A2 action is getting less pronounced. Ultimately, that leads to reduction in platelet aggregation and reduction in vasoconstriction, and that is how it has a anti-platelet action. As we say, it has two actions. One is anti-inflammatory and anti-platelet. So with a low dose, what we are getting is a anti-platelet action. I hope you all can understand the difference between low dose and adult dose. Now coming here, whenever we are giving aspirin with the full dose, adult dose, what it prevents is COX-2. COX-2 is cyclooxygenase enzyme 2. With that, there is reduction in all prostaglandins, so that there is reduction in pain, reduction in fever, and reduction in inflammation whenever aspirin is being given with an adult dose. But with a low dose, all these actions are not there. Reduction in pain, fever, inflammation is not there. But what is the main action is anti-platelet action whenever we are giving low dose aspirin. If you are asked in examination why we give low dose aspirin and why we are not giving adult dose aspirin during pregnancy, your answer should be with a low dose, it mainly prevents action of COX-1 and reduces the level of thromboxane A2, leading to reduction in platelet aggregation and reduction in vasoconstriction. And that is why we prefer low dose over the adult dose. If we are using the adult dose, on the other hand, what will happen is it will lead to the all the problems with the NSAIDs, such as it will lead to the especially in the third trimester, there will be oligohydramnios and there will be premature closure of the ductus arteriosus. With a low dose, aspirin is safe in pregnancy. Up to 100 milligram per day can be given, or we can say it can be given as 50 to 150 milligram per day with a dose of 1 to 1.5 milligram per kg per day. With a high dose, as I said earlier, there is constriction of ductus arteriosus with oligohydramnios, especially in the third trimester, as with other NSAIDs. So high doses should not be given in third trimester, but low dose has no such effect on the ductus arteriosus. There is no, what is most important is aspirin is not associated with any embryopathy, even if when it is being used in the first trimester. What are the indications and effects of use of aspirin in pregnancy? It leads to prevention of preeclampsia in high risk group. It also reduces, even if there occurs preeclampsia, it reduces the severity of preeclampsia. So first action is prevention of preeclampsia, and second action is reduction in the severity. Even if preeclampsia develops, it will be of non-severe variety. Third is related to preeclampsia is there is a delay in onset of preeclampsia. So rather than early onset preeclampsia, it will lead to a late onset preeclampsia, so that the effects on the fetus will be less, and overall this obstetric uh, overall obstetric outcome will be better. So what are the three actions of aspirin on preeclampsia? First is prevention, second is reduction in severity, and third is it delays the onset of preeclampsia. Then in SLE and in antiphospholipid syndrome, in both these conditions, aspirin is given along with heparin. Prevention of placental abruption is also occurs whenever we are giving aspirin, whenever the patient has got hypertension in pregnancy. Has been proven by various studies that it has been proven by randomized control trials also that whenever in a patient with hypertension in pregnancy we are using aspirin, there is reduction in the uh, complication of placental abruption also. So that is added advantage apart from these three actions. Reduction in spontaneous preterm birth is a questionable effect of aspirin, and it needs further research. Prevention of fetal growth restriction is seen whenever aspirin is being given in high risk group for preeclampsia. So with a high risk group of preeclampsia, if you are asked how it helps in high risk group of preeclampsia, you can say there are 5 actions together. What are the 5 actions? First is, just a minute, let me select. So first action is there is a prevention of preeclampsia. Second action is there is a reduction in severity. Third action is it leads to delay in onset of preeclampsia. Fourth advantage is it helps in prevention of placental abruption whenever it is being used in hypertension in pregnancy. And fifth action is it also prevents this fetal growth restriction occurrence whenever it is being given in women who belong to high risk group for preeclampsia. So in these women, whenever it is being given, these are the 5 actions, and I think as students you should be able to uh, talk about all these 5 actions whenever you are given aspirin and you are asked about aspirin in your table viva, grand viva, practical examination, or even if you get a theory question, if you get a short note on aspirin, you should be writing about all these 5 actions of aspirin. Prevention, reduction in severity, delay in onset, prevention of placental abruption, prevention of fetal growth restriction. It doesn't lead to prevention of fetal growth restriction in non-high risk group of preeclampsia. That is another important point to be remembered, that this action is only limited to women who belong to high risk group for preeclampsia. Prevention of fetal growth restriction. It is not seen in women who are not having any high risk factor for development of preeclampsia. Effects of aspirin in mechanical valve replacement pregnant patients. It is also given along with anticoagulants to prevent development of thrombus over these mechanical valves and development of embolism from these. Then it leads to, it leads to aspirin use is associated with reduction in superimposed preeclampsia in women with chronic hypertension. That is another advantage. It is also used in women with polycythemia vera complicating pregnancy, and in these women, now polycythemia vera means there is more of number of RBCs, and that is how there is a greater possibility that these women will be having more of clot formation also. But with the use of aspirin, this complication is again prevented. Whenever the woman has a renal disease completing pregnancy and aspirin is being used in these women, it helps in prevention of preeclampsia. In multiple pregnancy also, multiple pregnancy with a large placenta is a risk factor for development of preeclampsia, and use of aspirin helps in reduction in the number of women developing preeclampsia in women having multiple pregnancy. And in women with thrombocytosis, thrombocytosis is more greater number of platelets. These are also women who are more prone for development of thrombosis and complications of thromboembolism, and in these women also it helps in the prevention of this thromboembolism. So apart from preeclampsia, we have already seen high risk group for preeclampsia in the last slide. What are the additional advantage or situations where aspirin is used in pregnancy is mechanical valve replacement in women who are having chronic hypertension, polycythemia vera, renal disease complicating pregnancy, multiple pregnancy, and thrombocytosis in pregnancy. Coming to aspirin in preeclampsia, it is again I am repeating, it helps in prevention, it helps in of preeclampsia itself. It modifies the severity of preeclampsia by reducing the severity, but it needs to be started at less than or equal to 16 weeks of gestation. If it is started too late, I mean, if it is started in late second trimester, then this effect is less likely to be achieved. As per ACOG 2020 ACOG American College of Obstetrics and Gynecology guideline 2020, aspirin is to be given in high risk group for preeclampsia from 12 to 28 weeks till delivery. Now this is the range. If a patient directly comes late, she comes at 24 weeks, say, that doesn't mean that we should not be starting. We can start as late as 28 weeks, but the maximum benefit is there whenever we are starting it around at less than or equal to 16 weeks. Then in these cases, the benefit is maximum. Again, the same thing I have shown here. What is the mechanism of action of the aspirin? So mechanism of action is this I think each postgraduate student should be able to tell. Mechanism of action, that arachidonic acid is getting converted to thromboxane A2 with the enzymatic action of this COX-1, and this as it is a inhibitor of this enzyme aspirin, it reduces the level of thromboxane A2 in the blood. So reduction in thromboxane A2, but the prostacyclin is remaining normal. So that what it will lead to will be a greater action of prostacyclin. So that this balance will be going like that. Prostacyclin heavier, greater action. Thromboxane A2 lighter action. So this balance will be shifted. Normally there is a balance between these two, but here there is more pronounced action of prostacyclin, and that is how it leads to the reduction in platelet aggregation and reduction in vasoconstriction. Should be at the tip of the tongue for all the postgraduates whenever you are going for practical examination, that how aspirin acts and how it leads to all these actions for the reduction of preeclampsia as well as reduction of fetal growth restriction. That placental changes, whatever placental circulation is getting affected in cases of hypertension in pregnancy and fetal growth restriction, all those placental circulation changes are prevented by the use of aspirin, and ultimately it leads to prevention of hypertension, preeclampsia, reduction in severity, delay in onset of preeclampsia, reduction in abruption, reduction in fetal growth restriction in women with preeclampsia. And aspirin also helps us in chronic hypertension for prevention of superimposed preeclampsia, renal disease complicating pregnancy for development of preeclampsia. It helps in prevention of thrombosis in women with polycythemia vera as well as thrombocytosis. That is how you can remember the indications and effects of aspirin use during pregnancy. What is questionable at present is its indication as its use for prevention of preterm labor needs further research. So naturally, the next question which you will be asked whenever you are given aspirin, say for your table viva is, if you say this is indicated in women with high risk group for eclampsia, what do you mean by that? You will be asked, what do you mean by high risk group for preeclampsia? Or in other words, what are the indications for prophylactic aspirin use during pregnancy? This is one and the same. What is the high risk group for preeclampsia, or in which women you will start aspirin prophylactically? What are the indications for the use of aspirin during pregnancy? So left side is the group which has slightly higher risk, so that you need more than or equal to one indication to start aspirin. In other words, even if there is a single indication, it is sufficient to start aspirin, low dose aspirin in early pregnancy. Here the risk factors are less severe, so that you need greater than or equal to two risk factors to start it. So how you remember is here. If there is a previous history of preeclampsia, is easy to remember. A woman with chronic hypertension, you start. Over diabetes mellitus, whenever there is a diabetes mellitus vasculopathy, whatever vasculopathy is there, there is a risk for development of preeclampsia. That is how we remember. Then renal disease, again the same thing, that whenever there is a renal disease, superimposed preeclampsia can develop. Any autoimmune disorders such as antiphospholipid syndrome or any other autoimmune disorders, patient will be more prone for development of preeclampsia. And in multifetal gestation with a larger size of the placenta and more of changes which are taking place in the trophoblastic circulation, there is a high risk factor for development of preeclampsia. So that is how anyone, even if patient has only multifetal pregnancy, twin pregnancy, it is an indication to start aspirin from early gestation. If woman has over diabetes mellitus, it is an indication. So more than or equal to one means any one is sufficient. On the other hand, here we have less severe indications, such as now nulliparity is so common. But with nulliparity, if there is a combination of nulliparity along with elderly woman, age greater than 35 years, then remember that it will be an indication. So these common conditions we should remember, that so many now obesity is on the rise. So woman is nulliparous and she is obese. Again, it will be an indication to start aspirin. Family history of preeclampsia. Then vulnerable socio-demographies mean patient belonging to lower socioeconomic status and prior low birth weight or fetal growth restriction, neonate. That will also be. So greater than one. If there are any two of this combination of, suppose this is very common, so many times we do get women from lower socioeconomic status with nulliparity. So with this also combination also will be an indication to initiate the aspirin from early pregnancy. I think this should be in a chart, from which we should display these indications for the starting aspirin in pregnancy or high risk group for preeclampsia in our outpatient departments, so that we do not miss any indication and we start the this aspirin in indicated women, so that they get maximum benefit of all these actions: prevention, and delay in onset, or reduction in severity of preeclampsia, reduction in abruptio placentae, reduction in fetal growth restriction. All these advantages women can, or superimpose preeclampsia whenever there is a chronic hypertension, renal disease, or with over diabetes mellitus. So if we have this in our outpatient department, many women will get the benefit of our knowledge. If you are asked whether aspirin is safe during pregnancy, so it is definitely, it is safe during pregnancy, provided we are using a low dose. Higher dose is not safe in third trimester, but in low dose up to 100 milligram per day, it has no effect on ductus arteriosus. Otherwise, there is a premature closure of ductus arteriosus, and that reduces the production of amniotic fluid because of the reduction in fetal urinary output. So low dose is safe in third trimester. High dose in third trimester, ductus arteriosus constriction can occur and there can be oligohydramnios. So whenever you are asked whether aspirin is safe in pregnancy, your answer should be low dose is safe. So you focus here, low dose. Low dose is safe, high dose is not safe. So you should answer. You should never say that aspirin is absolutely safe in pregnancy. You should say that safety depends on the dose. Low dose is safe, high dose is not safe in third trimester of pregnancy. But there are no teratogenic effects when it is given in first trimester, and there is, even if you take a patient for say for a cesarean section and woman is on aspirin, it doesn't lead to increase in intraoperative blood loss is additional benefit. That is why whenever we are starting this aspirin in early pregnancy, all the recommendations say that we can continue it till delivery. There is no need to stop it, say after 36 weeks of pregnancy, because as the woman reaches nearer the term, the risk of development of preeclampsia increases. So there is no need to stop aspirin even after 36 weeks. It can be continued till delivery. Now we come to the second drug. I have selected these two drugs together. There are because in many indications these are used together, and frequently asked. These are the commonly used drugs and frequently asked in your examination also. So with heparin we have two types. As you all know, this is unfractionated heparin and this is a low molecular weight heparin. All of you must be using one of these two, must have used during your training period, or consultants also must be freely using one of these. Now, unfractionated heparin is cheaper as compared to low molecular weight heparin, and that is the reason in so many times in developing countries still we are compelled sometimes to use unfractionated heparin because of the increased cost associated with low molecular weight heparin. Now, whatever type we use, it is not crossing the placenta is the advantage. That is a big advantage, and that is why it has no effect on the baby. It is not crossing the placenta. We should remember that whatever we are using heparin, is never going to cross the placenta. That is important. Heparin is not crossing the placenta, and that is how it doesn't cross the placenta, and that is how it doesn't reach to the baby. It is not passing through the placental bed. What is it? How it acts? It has got coagulant action by activating antithrombin. Now, along with it has got equal action. This unfractionated heparin, it has equal action against thrombin and factor 10A. Now these two we should remember, thrombin, and it has got antagonistic action against thrombin. That is how it acts as anticoagulant, as well as against factor 10A. Whereas if you compare these two, mechanism of action differs slightly. With LMWH, the action is more pronounced against factor 10A with low molecular weight heparin. Now, molecular weight of this unfractionated heparin is 12,000 to 16,000 daltons, whereas low molecular weight heparin molecular weight is 4,000 to 5,000 daltons. That is why we call it as a low molecular weight heparin. Indications of heparin use in obstetrics. That was the question which was asked by one of our viewers also, because I could understand why um, that question came, because there is so much of confusion related to the thromboprophylaxis in pregnancy. If you see the guidelines, there is so much of drastic difference between the indications of thromboprophylaxis during pregnancy, and that is why there is no clear picture at present. If you see all the textbooks, if you see all the guidelines, and if you want to know the indications for the use of heparin in obstetrics, there is no consensus even among the commonly used guidelines also. American guidelines, UK guidelines, Canadian guidelines, Indian guidelines, whatever guidelines you see, there is so much of difference in the guidelines at present because the evidence is not strong. At present, is guideline is based on evidence, and evidence is still strong evidence is still lacking, and that is why the picture is not very clear about it. But there are certain indications where there is a clear-cut indication to use this uh, heparin during pregnancy. Clear-cut indications, we can say thrombophilia. Now, meaning of thrombophilia is a condition whenever there is an increased tendency for development of thrombus. That is why we call it as thrombophilia, which can be either hereditary or acquired. In the hereditary, we have so many conditions, such as there can be uh, with this protein C, protein S deficiency, or there can be a factor 5 laden mutations can be there, or in acquired, the common in acquired is antiphospholipid antibodies leading to antiphospholipid syndrome, APS. APS, that is antiphospholipid syndrome, is acquired thrombophilia. So hereditary or acquired thrombophilia, we are commonly using this um, heparin. Second is management of VTE, that is venous thromboembolism, or whenever there is a prior history of venous thromboembolism, then there is no doubt that we need to use it. So these are the common. These two I have no, there is no doubt. All the guidelines are telling us that we need to use heparin whenever there is either patient has got thrombophilia and either whether there is a previous history of VTE, combination of these two, then it will be a definite indication. Whenever these two are together, thrombophilia with previous history of, say, venous thromboembolism. And whenever a woman develops venous thromboembolism, as a management, also use of heparin is beyond doubt. Whenever there is a mechanical heart valve, suppose patient has got a mitral stenosis or aortic stenosis and valve replacement has been done, and the valve which is used is a mechanical heart valve. These are the cases where the mechanical heart valve is associated with increased possibility of development of thrombus there, and that thrombus can then get dislodged and that can lead to embolism, and that is why this is an absolute indication for use of heparin. Now, minor indications are these, such as superficial venous thrombophlebitis in varicosities. Severe when there is frank varicosities is one of the indication. These are minor. Or at intravenous site there is a thrombophlebitis. Or in patient women with peripartum cardiomyopathy, when we are treating a woman and when ejection fraction increases and goes beyond 30%, then to prevent left ventricular thrombi, we have to use heparin. So these are the conditions where this peripartum cardiomyopathy with a ejection fraction greater than 30%, then only we can use. But this superficial venous thrombophlebitis is comparatively a minor indication as compared to these first three. So whenever you are asked about the indications for heparin, thrombophilia, VTE, venous thromboembolism, mechanical heart valve, these are clear-cut indications for the use, whereas thromboprophylaxis, when these are absent, there is no history of thrombophilia, either hereditary or acquired, and there is no history of this venous thromboembolism. There is no heart disease with mechanical heart valve replacement. In these situations, sometimes it is very difficult to select a woman who needs thromboprophylaxis, and that is why there is so much of ambiguity related to the use of heparin in conditions where these risk factors are not there, but still we need to use it. That means in low risk cases, comparatively low risk cases where we are using thromboprophylaxis, there is a difficulty to remember the indications. As already we have discussed, indications of thromboprophylaxis for this prevention of venous thromboembolism in pregnancy, there are major differences in guidelines. For example, ACOG, it says that you assess the individual risk, but the risk factors are not well defined by ACOG itself, by this body. Whereas RCOG or NICE, previously also I said that RCOG, it is a Royal College of Obstetrics and Gynecology, which is mainly conducting the training and providing the degree, postgraduate degree to the postgraduates in United Kingdom. Whereas NICE is the body which comes under the run by government of UK, and this government of UK guidelines are now replacing NICE guidelines, are also almost replacing these RCOG guidelines. So both these are belonging to United Kingdom. Now by NICE guideline, there is a wide inclusion of risk factors and there is a comparatively a greater clarity, and that is why I have selected, excuse me, this NICE guideline to discuss the thromboprophylaxis further. Now, this is the most difficult part of this today's topic of discussion, that risk score for venous thromboembolism in pregnancy. And each, now we can see here on the left side, it is score 1, then score 2, score 3, and score 4. And greater is the score, greater will be the risk of development of venous thromboembolism, and there it will be an clear-cut indication for starting thromboprophylaxis, in other words, starting heparin during pregnancy. Let us see for score 4 first. Whenever there is a history of previous venous thromboembolism, except single event because of major surgery. Suppose patient has got a major surgery in the past and there is only single event of VTE, it comes under score 3. Apart from that, there is no history of major surgery and there is a, in isolation, there is a development of venous thromboembolism, it comes under score 4, which is the highest score. Score 3 has more situations. This is the only situation in score 4 we can remember that way. Previous VTE without major surgery, not a single event associated with major surgery, is only single condition which has a highest score of 4. Whereas for score 3, if there is VTE, previous VTE with major surgery, single event, that is score 3. Known high risk thrombophilia is score 3. Now, high risk thrombophilia is whenever there is antithrombin deficiency, protein C deficiency, protein S deficiency, or factor 5 laden mutation along with any other risk factor. So remember, these 4 are coming under high risk thrombophilia. I will repeat once again: antithrombin deficiency, protein C deficiency, protein S deficiency, factor 5 laden mutation along with some associated risk factor. These come for all these conditions come under the umbrella of high risk thrombophilia, which carries score of 3. Medical comorbidities carry score of 3, such as patient has cancer, heart failure, irritable bowel disease, sickle cell disease, active SLE, type 1 diabetes with nephropathy, nephrotic syndrome, or patient is a current IV drug user. All these medical comorbidities are a very high risk factor for development of venous thromboembolism, and that is why it has been given a score of 3. Next scenario is, we have seen first, second, and third. Now coming to fourth scenario is, whenever a patient undergoes any surgery during pregnancy or puerperium except perineal repair, such as appendectomy done during pregnancy or puerperium, or even a postpartum sterilization also comes under this, and it has got a high score of 3. And last is, whenever there is hyperemesis and a woman is dehydrated, it is a very high risk factor for development of venous thromboembolism. We should all remember, because we do face women who come to us with hyperemesis too late and they are already dehydrated, and these are the women who are carrying very high risk for development of venous thromboembolism, and that is why score of 3 is given. Remember that score 4 and score 3 are very high risk situations for development of venous thromboembolism. Comparatively, score 2 and score 1 are low risk. Score 2 is whenever emergency cesarean section is there done in labor, intrapartum cesarean section, score 2. Whereas elective cesarean section goes to, elective cesarean section is score 1. I think I have forgotten to mention it here, but elective cesarean section has got a score of 1, and emergencies here. See, we can see here elective cesarean section score of 1. All green is score of 1. This blue is score 2. This purple is score 3, and red is score 4. So for a score of 2, cesarean section in labor, or whenever there is a BMI greater than or equal to 40. Then obesity with a BMI of greater than or equal to 40 comes under score 2. Score 1, pre-existing factors such as family history of VT, low risk thrombophilia where there is a factor 5 laden mutation in isolation. There is no other associated risk factor. Associated risk factor, it comes under score 3. No associated risk factor, only factor 5 laden mutation comes under score 1. Prothrombin gene mutation and increased levels of factor 8. These are the three low risk thrombophilias. Age greater than 35 years, BMI 30 to 39. Greater than 40 BMI comes under score 2, whereas 30 to 39 comes under score 1. Parity greater than or equal to 3. Woman is a smoker or has gross varicose veins. All these pre-existing factors are carrying a score of 1. Woman has any infection such as urinary tract infection, score of 1. Immobility, especially because of the pelvic girdle pain, that comes under score 1. Obstetric risk factors such as preeclampsia, PPH, elective cesarean section, preterm labor, multifetal pregnancy, prolonged labor greater than 24 hours duration of labor, stillbirth in the current pregnancy, and in current pregnancy, mid-cavitary instrumental delivery. All these are obstetric risk factors carrying score of 1. So how to remember is, remember that VTE goes to 4 and 3, thrombophilia is going to 3, medical comorbidities is 3, surgical procedures in pregnancy puerperium is 3, and hyperemesis with dehydration is 3. If you remember 3 and 4, it is easier to remember what is 2 and 1. 2 has only 2, cesarean section in labor, BMI greater than or equal to 40, whereas all the rest are score 1. Pre-existing factors such as age, BMI, 30 to 39, parity, high parity, smoking, gross varicose veins, low risk thrombophilias, family history of venous thromboembolism, any infection, immobility, or obstetric risk factors wherever there is an increased risk of thrombosis, such as preeclampsia, PPH, elective cesarean section, preterm labor, multifetal pregnancy, prolonged labor, stillbirth, mid-cavitary instrumental delivery, all these are carrying a risk of only score of only 1. I hope that somehow you will all remember these risk factors. Scoring also is very important because that shows us the spectrum that if you have a, for example, you have parity greater than or equal to 3, it immediately you should start thinking about thromboprophylaxis. If a woman has got, say, appendicectomy during pregnancy, you should know that it has got a very high score of 3, and you should start thinking about thromboprophylaxis. Even medical disease, woman having heart failure, you start thinking about initiating thromboprophylaxis. How you convert this knowledge in practices, score, and this is the action what we need to consider. So greater than or equal to 4 is the score in antenatal period, LMWH or thromboprophylaxis from first trimester itself. If there are total score is greater than or equal to 4, that means there is, suppose patient has got appendicectomy and she has also another factor which goes in favor of score 1 only, then also the total score will be 4, such as she has multifetal pregnancy, say, then that will be score 4, and you need to consider initiating thromboprophylaxis from first trimester itself if appendicectomy has been done in first trimester. Score of 3 antenatally, then we should start thromboprophylaxis from 28 weeks. That is how this scoring system helps us. Postnatally, now it is said that this scoring needs to be assessed repeatedly throughout pregnancy. That means you assess in first trimester, again assess it in second, then in third trimester, and again in labor and postpartum you reassess. So it is not that once you assess it is over, because patient's condition is dynamic, it keeps on changing. We need to reassess the risk at each stage during pregnancy. So again you reassess in postnatal period, and greater than or equal to 2 score of greater than or equal to 2 is an indication to start this thromboprophylaxis, and it should be given for at least 10 days. And if the risk is greater, score is greater, it should be given for 6 weeks also. Any woman having antenatal hospital admission, consider thromboprophylaxis, as she will be having less ambulation, because pregnancy itself is a hypercoagulable state with an increased risk of thromboembolism, and there are so many times we get unfortunate incidences of maternal mortality because of pulmonary embolism. And to prevent that, we need to be more sensitive and more aware that any patient who is not ambulant is a risk factor, and we need to consider this thromboprophylaxis or low use of low molecular weight heparin. Even postnatal, there is a readmission. Patient has delivered, gone back, and again came back for any other indication for readmission, and ambulation is less. Again, consider thromboprophylaxis. In mechanical valve replacement, there is a tricky situation because there is a very high risk of development of thromboembolism, and warfarin is unfortunately most effective. It is more effective than heparin to prevent thromboembolism, but it causes embryopathy. Warfarin has teratogenic action, it causes miscarriages and stillbirths. Heparin is less effective, but it is safer for the fetus. Whenever we are giving heparin or warfarin in for this indication, it needs full dose anticoagulation with either this any type of heparin with, how you know full doses, with APTT at least double the normal. Activated partial thromboplastin time should be measured, and should be at least double the normal, that is full dose of anticoagulation. And whenever it is being given, there is increased risk of hemorrhage, and that is why a woman needs to be monitored meticulously. LMWH is preferred over this unfractionated heparin because of more efficacy to prevent valve thrombosis in these women. Warfarin or heparin are restarted 6 hours after delivery and 12 hours after cesarean section, and both any of these are safe during breastfeeding. So how it is given is, first trimester you give heparin, second and third trimester you shift to warfarin once the organogenesis is over. Again, after 36 weeks, you know that the heparin, if especially low molecular weight heparin, if it is long acting, and so the risk of patient having a problem with the spinal anesthesia will be more of, and that is the reason after 36 weeks shift back to warfarin. Immediate postpartum, you give combination of warfarin and unfractionated heparin, and then gradually after, once the patient settles, then you shift to only warfarin. So that is how these are the various ways of combining in these women with mechanical heart valve. Now, heparin use and spinal anesthesia, there is a risk of spinal cord hematoma and compression. What we are worried about is, whenever the woman is on heparin and whenever we need to do cesarean section, say in emergency, what can happen is there can be bleeding inside, and that can lead to spinal cord compression, hematoma formation, and compression. Spinal analgesia is contraindicated with low molecular weight prophylactic use of low molecular weight heparin whenever it is being given and duration is less than 12 hours. Suppose we have given this low molecular weight heparin at say 8 a.m. Then before 8 p.m. we cannot give spinal analgesia. Therapeutic LMWH needs to be, there has to be a gap of greater than 24 hours to give spinal analgesia. Prophylactic use of unfractionated heparin with a dose of 5,000 units twice a day is not a contraindication for spinal analgesia. This is the lowest dose, and for that there is no risk of this spinal cord hematoma or compression. With intermediate dose of unfractionated heparin, 7,500 to 10,000 units, there is a low risk of spinal analgesia, and it can be used with a low risk within 12 hours. But with higher dose greater than 20,000 units, spinal anesthesia has a higher risk when used after 24 hours. Provided it can be used provided after 24 hours, provided APTT is within normal limits. But there will be a greater risk with a higher dose. What are the comparison of this LMWH and unfractionated heparin? Advantages of LMWH are better bioavailability, longer half-life, more predictable dose response, reduction in complications such as osteoporosis and thrombocytopenia, and it needs less frequent dosing. Both are given subcutaneously, but LMWH can be given once a day for prophylactic use, whereas twice a day for therapeutic. Whereas unfractionated heparin, double dosing is required as compared to LMWH. Disadvantages of LMWH are it is not safe near term because of increased risk of spinal cord hematoma with spinal analgesia during labor or cesarean section. So near term better will be unfractionated heparin as it is short acting. Now this LMWH is cleared by kidneys, needs cautious use whenever there is a renal disease, and it is comparatively expensive as compared to unfractionated heparin. This is a commonly asked question, why we prefer LMWH over unfractionated heparin, and what is the disadvantage? Major disadvantage is this, that it is long acting, so it remains in the circulation for a longer time. So we have to wait for a longer time whenever we need to give spinal analgesia. आपला antiphospholipid antibodies in pregnancy. Low molecular weight heparin is given if there are associated risk factors. And why we are giving whenever there is a patient has antiphospholipid syndrome and associated risk factors are there for venous thromboembolism. Then to prevent venous thromboembolism, we are giving thromboprophylaxis or low molecular weight heparin or whatever heparin a patient can afford. But whenever there is associated history of recurrent pregnancy loss or stillbirth, in that case, whenever we use heparin, it is being used to improve pregnancy outcome whenever it is being given in antenatal period, and it is given postnatally mainly to prevent VTE. So antenatally, whenever there is a recurrent pregnancy loss or stillbirth history is there in a woman who has antiphospholipid antibodies, then it is indicated to give heparin, and in that case our indication is not prevention of venous thromboembolism, but indication or effect is it improves pregnancy outcome. Thank you so much. I have mainly gone through Williams 2090, and this is important guideline. NICE guideline 2015. I hope that it helps in clearing some of the doubts related to thromboprophylaxis and use of heparin during pregnancy, as well as use of aspirin, low dose aspirin during pregnancy. Thank you once again.